Welcome everyone to this explainer. Today, we're diving into something that is absolutely fundamental in modern medicine, the nasogastric tube. Now, at first glance, you might just see a piece of plastic, but I really want us to reframe that right out of the gate. This is a critical medical lifeline. I mean, it's a total game changer for patients who can't eat, who can't swallow safely, or who desperately need their stomachs emptied. It's this fascinating procedure that blends precise human anatomy, physics, and honestly, deep empathy. So we're going to break down the exact clinical protocols that healthcare providers use to insert and manage these tubes safely. Let's get right into it.
To keep things perfectly clear, we'll follow a strict clinical checklist today. We'll cover the basics and the why, assessment and preparation, the insertion procedure itself, verifying correct placement, securing and daily care, and we'll wrap up with lifespan considerations specifically for infants.
All right, Section 1, the basics and the why. So, a nasogastric tube navigates a very specific anatomical path. It goes right through one nostril, glides down the nasopharynx, and passes into the alimentary tract, specifically the stomach. But there is a huge prerequisite here. Patients absolutely must have intact gag and cough reflexes. Why? Well, because if those reflexes are absent, the risk of accidentally placing this tube into the patient's lungs just skyrockets. It's a vital safety checkpoint we have to clear before we even think about beginning.
When it comes to the equipment, we're generally looking at two categories. On one side, you've got large bore tubes. These are greater than 12 French in diameter. Think of your traditional firm tubes, like the single-lumen Levin tube or the double-lumen Salem sump. That Salem sump is actually pretty brilliant. It has this smaller vent lumen, usually called a blue pigtail, that lets atmospheric air in. That prevents a vacuum from forming and irritating the stomach lining during suction. On the flip side, we have small-bore feeding tubes, or SBFTs. These are smaller than 12 French, way softer, much more flexible, and a lot less irritating. That makes them the absolute go-to when we're strictly talking about enteral nutrition.
So why put a patient through this in the first place? There are 4 primary life-saving reasons. First, to administer tube feedings and medications for folks who just can't eat by mouth without aspirating. Second, to suction stomach contents. This prevents really dangerous gastric distension, nausea, and vomiting. Third, to pull those contents out for critical lab analysis. And fourth, to lavage, or essentially wash out the stomach. That last one is quite literally a lifesaver in cases of poisoning or a medication overdose.
Moving right along to Section 2, assessment and preparation.
Preparation is all about maximizing patient comfort and safety. First up, if their health allows it, we help the client into a high Fowler's position, basically sitting straight up. This makes swallowing easier and lets gravity do a lot of the heavy lifting. Second, we verify identity and explain what we're doing. Third, we establish a physical distress signal, like raising a hand. Passing this tube triggers the gag reflex, so the patient needs a clear way to tell us, hey, I need a break. Now here's a really fantastic clinical trick for you. If you're using one of those firm, large-bore tubes, you can actually place it in a basin of warm water to soften it up and make it more pliable. But if it gets too soft and you can't control it, just dip the end in ice water and it stiffens right back up.
Now for the main event. Section 3, the insertion procedure.
Before we insert anything, we have to know exactly how far to push the tube. We measure from the tip of the client's nose, over to the tip of their earlobe, and then straight down to the tip of the xiphoid process, right at the base of the sternum. Because this anatomical distance varies wildly from person to person, we mark this specific, customized length with a piece of adhesive tape directly on the tube. Next, we need to lubricate the tip. And guys, the type of lubricant you use is literally a matter of life and death. We must use a water-soluble lubricant. The clinical rationale here is that if the tube accidentally slips into the lungs, a water-soluble lubricant will safely dissolve. If you were to use an oil-based lubricant, like petroleum jelly, it will not dissolve and it can cause severe, life-threatening respiratory complications.
Okay, let's start the anatomical journey. We insert the tube into the nostril that has the greatest airflow. First, we ask the client to hyperextend their neck backward. This reduces the initial curvature of the nasopharyngeal junction. But once that tube reaches the back of the throat, the oropharynx, they are very likely going to gag. Immediately, we have them tilt their head forward to help guide the tube into the esophagus instead of the larynx. Finally, having them drink and swallow water acts as a mechanical shield. It pulls the epiglottis directly over the opening of the larynx, protecting the airway while we advance the tube about 5 to 10 centimeters with every single swallow.
Which brings us to a super critical phase. Section 4, verifying correct placement. So here's the million-dollar question. How do we actually know the tube is safely in the stomach and not the lungs? Well, the only truly definitive method, especially for those small bore feeding tubes where the guide wire is still in place, is an X-ray. The tubes are radio opaque, so they pop right up on the film. But if an X-ray just isn't feasible, we have to rely on secondary bedside tests. Right away, if you're using a CO2 detector and you draw air through it and the color changes, that means the tube is in the respiratory tract. You must withdraw it immediately and start over. No exceptions.
If we don't have an X-ray, we rely on aspirating or pulling back fluid from the tube. Take a look at these stomach values. You want a highly acidic pH, typically between 1 and 5, and the bilirubin level will be right around 1.5 milligrams per deciliter. Contrast that with the lungs, where bilirubin is basically 0, or the intestines, where the pH jumps up to 6 or greater and bilirubin is over 10. And I really need to call this out explicitly. Historically, nurses used to push air into the tube and listen over the stomach with a stethoscope for a whoosh sound. Actually, scratch that old method entirely. We now know it does not guarantee tube position and is dangerously unreliable. Always follow the science, pH and bilirubin.
Okay, we're in. Section 5, Securing and Daily Care. To lock this down, we take a piece of tape, split it lengthwise at one end, and lay the solid end right over the bridge of the nose. Then we wrap those split ends around the tube. The secret here is centralizing the tube in the nostril before you tape it down. If it presses against the edge of the nares, it causes terrible, painful irritation. We then pin the tube to the patient's gown so it isn't dangling or pulling. Oh, and for that Salem sump tube with the blue vent port we talked about, we attach the anti-reflux valve and position that port above the client's waist so gastric contents don't leak out. Once it's secured, you know the drill. Documentation is everything. A real-world entry requires absolute precision. Take a look at this example. 11-5-15-10-30, number 8 French feeding tube inserted without difficulty. Radiologist reports tube tip in stomach. Aspirate pH 4, tube secured to nose. You see the exact date and time, the size and type of the tube, the confirmed X-ray by a radiologist, and that secondary check with an aspirate pH of 4. Daily care then kicks in, meaning highly accurate records of fluid intake, what the drainage looks like, and keeping those nostrils clean. Finally, let's look at Section 6, Lifespan Considerations for Infants. There is a surprising, absolutely massive rule when dealing with infants. Do not hyperextend or hyperflex an infant's neck during this procedure. While tilting the head was super helpful for our adult patients, infant anatomy is vastly different. Bending their little necks too far in either direction could easily pinch off and occlude their tiny airway entirely. Because of that, our measurement math changes completely for these vulnerable patients. Remember, for an adult, we measure nose to earlobe to xiphoid process. But for an infant, we measure from the nose to the earlobe and then down to a point exactly midway between the umbilicus, the belly button, and the xiphoid process. Also, because their nasal passages are so incredibly small, infants might require an orogastric tube instead, which goes through the mouth. Plus, they almost always need restraints to stop them from accidentally yanking the tube out.
We've covered a tremendous amount of ground today, and I want to leave you with one final thought. In high-stakes procedures like this, how does understanding the why behind the what transform a rigid protocol into true life-saving patient care? Think about it. We didn't just memorize a checklist today. We learned exactly why water-soluble root protects the lungs, why swallowing acts as an airway shield, and why an infant's neck has to stay perfectly straight. It's this meticulous blend of anatomy, physics, and deep human empathy that truly defines incredible patient care. Thanks for walking through this explainer with me. Take these insights, apply them out there, and keep learning.